Dear chairmen, dear colleagues, our topic today is related to multivisceral resections, and the core problem actually is related to several questions that sometimes the answer is not so clear and not so easy. So can I achieve R0 block and block resection, and is the biology locally dominant or systematically aggressive, and is the surgery best performed now after neoadjuvant chemotherapy or TNT or not at all? So to find the answer, we have to discuss the multivisceral resection in comparison to primary organ-only resection versus chemotherapy only or continuing oncologic therapy, upfront surgery versus neoadjuvant first sequencing, or open versus minimally invasive multivisceral resection. So the endpoint is not just more organ removed, but durable R0 resection without futile morbidity or loss of systemic therapy. And when we speak about multivisceral resection, we have to discuss that it's not clear about the different organs. And for retroperitoneal tumors and sarcomas in particular, actually the situation is quite clear, and we can discuss that tumors as a benchmark rather than the controversy. All of us know that if we have involvement of adjacent organs, the multivisceral resection is a must, and that is proved by the cited studies. I will be as quick as possible because we are running out of time. The real controversies are actually the gastric cancer, pancreatic cancer, and the colorectal cancer. And not intentionally, but the paper is really good. Actually, we choose the systematic review of Professor Skizas from 3 years ago, and about more than 3,000 patients. So the pooled R0 rate was 67.8%. You can see the most common complications, and the survival actually is quite optimistic. So in the same paper, the survival was better when only one additional organ was resected than more than once, but highlighting that the biology and the operative selection rather the extent alone are more important. But in a different paper of this, when the propensity score match analysis was done, comparing the postoperative complications, the 19-day mortality, and the overall survivor, actually was no longer significantly different between multivisceral resection and a standard gastrectomy for not so advanced cancer. So we can conclude that compared with primary organ-only resection, multivisceral resection can recover the oncological adequacy in selected T4B patients compared with biologically adverse disease. However, the extent of the operation alone does not rescue the outcomes. For the pancreatic cancer, we've already discussed that during the previous sessions. So only about 20% of the patients are resectable at the diagnosis, and because of that, the role of the neoadjuvant chemotherapy is increasing. So for borderline tumors, the situation is quite clear, and multiple studies shows that when we have resectable cancer, the neoadjuvant chemotherapy has not so much advantage. So therefore, the indications for extended surgery of PDAC is not only can I remove it, but has systematic therapy identify a tumor biology still worth resecting. And from target trial from 2024, almost 2,000 patients, the 3-year survival was 39.7% after after surgery versus 22.7% after chemotherapy without surgery. So it's absolute difference of 17%. For a multicentric study from the 2025, the borderline or locally advanced PDAC responding to chemotherapy, in that situation, the median overall survival was 39 months with resection versus only 16.7 months with continuing oncologic treatment without surgery. So, however, the extension of the operation has a price, and analysis over 24 more than 24,000 pancreatic duodenectomies shown that the morbidity is higher, and if concurrent colectomy occurs in only 1.8%, independently double to triple the serious morbidity. So in PDAC, we can conclude that the multivisceral resection, and that in the most cases is resection, vascular resections, is justified mainly as a conversion or selected patients, especially after favorable systemic control. For colon cancer, we can conclude that we can accept a higher morbidity for en bloc radicality, and here you can see a study showing that the survival rate is significantly higher in advanced stage of right colon cancer if the multivisceral resection is performed in cases of infiltration of adjacent organs like the duodenum and the pancreas. But in 2023, you can see a multi-center observational study with a lot of patients recruited in it, that in the matched colon cohort, the overall 5-year survival was lower than in non-multivisceral resection, reflecting more the advanced disease rather than the failure of the en bloc resection. Another paper actually from 1 month ago showed us that 3 years disease-free survival and their overall survival are comparable with the non-multivisceral resection and multivisceral resection group. So we can conclude that compared with the peeling off or local resection, and block multivisceral resection offers better survival chance, but compared to the with standard resection for biologically less advanced tumors, complications are higher, but the oncology adequacy can be restored. For the rectal cancer, the timing is very important, and from systematic review from 2025, the R0 rates after pelvic excitation ranged from 23% to almost 100%, so very heterogeneous results. The overall morbidity ranged from 17 to 87, and the median survival range between 12 to 140 months. So quite controversial as a result. Another paper from the National English database over about 3,000 exenterations found that the 5-year overall survival improved from 37% before 2005 to 61% after the 2005. That's the survival, consistent with MRI-based selection and specialized BOMT surgery. Another analysis, a recent analysis, found that in T4 advanced rectal cancer, the 5-year survival was 72% with surgery versus only 44.5% with non-operative management. About the colorectal metastasis, very interesting paper, umbrella review over 17 randomized trials that conclude that it's about the simultaneous resections of the colorectal metastasis. That in selected cases, the overall survival is very similar to these, that it's only about the colorectal metastasis, but the morbidity rate is higher. So it should be done in selected cases. And the impact of the multivisceral liver resection, that means the resection of the liver with mainly concomitant vascular resection, is feasible and safe and restore the overall survival with not so advanced cases. But again, it carries a higher risk of major complications and do not worsen the long-term results. And again, it should be done in specialized centers and selected cases. So on this algorithm, we've tried to show possibilities for multivisceral resections and maybe to give a attempt for answer when to choose the multivisceral resection or to try with neoadjuvant chemotherapy. And the favorable biology is related to lower tumor burden, lower limited nodal disease from the images, low CA99, for example, stable disease or resectable metastasis. So in these cases, the multivisceral resection is an option for as a primary treatment. In the other cases, we can discuss the neoadjuvant chemotherapy. So now we will give you a frank own material, and it's for the last 2 years. It's about 121 patients who underwent multivisceral resection due to oncological diseases in our clinic. And our goal is to share experience first of all, because you can see the patients with advanced stages of cancer are too frequent. And the other thing is we discussed the neoadjuvant chemotherapy and SNS, but sometimes because of development of surgical complications because of the tumor or something like that, the neoadjuvant chemotherapy is not an option. And the multidisciplinary team, it's very important. So sometimes it's very tricky to decide what to do, or the approach has to be highly individualized. So on the table, you can see the distribution of the primary cancer. Morbidity is quite high or typical for the general cohort in our clinic. It's about 20%. The mortality rate is again higher than the other patients, and that's related to the advanced stage of the patient. So if we analyzed the type of performed operations, no dominant resection pattern cannot be identified, and that's again because of the advanced stage of the patients, and that we should individualize the approach. So on the table, it's quite different situations with patients with gastric cancer, from gastrectomy with splenectomy to combined resections with left pancreatic resections, intestinal resections, bowel resection, or Whipple procedures combined to the gastrectomy. In the colorectal cancer, the most common combinations are the pelvic exenteration, partial resection of the urinary bladder, and the liver resection. And in the cases of pancreatic cancer, in the most cases, we combined the resection with the resection of the portal vein when we speak about the right localization of the tumor. And now we would like to share some several cases that was tricky for managing and decision making. The first one is 48 years old female, CT data for gastric cancer with necrotic areas, soft tissue lesions in the left pericolic region and involvement of descending colon. So we perform a quite extensive procedure with gastrectomy, omentectomy, splenectomy, left pancreatictomy, and resection of the colon. That decision was made because of the clinic of the patient. You can see that the colon is almost obstructed, and the patient was consulted in oncological board. So the decision there was for operation 2. Another tricky case, it was 66-year-old male, CT scan with a quite large formation, dislocating the spleen, the left kidney, and the stomach with possible involvement, circumferential involvement of the splenic vein in the artery, and intra-abdominal growth inside of the left renal vein, and extension to the tail of the pancreas. So we perform gastrectomy, left pancreatic resection, extirpation of the tumor with left nephrectomy, suprarenalectomy, splenectomy, omentectomy, suture of the diaphragm, and drainage of the pleura. The histology was quite interesting for us. It's the adrenocortical carcinoma with rhabdomyoid differentiation and vascular invasion, as well infiltration of all of the removed organs. Here you can see the postoperative CT scan during the follow-up. There is no signs of recurrence. There was only a collection around the surface of the resected pancreas that was treated conservatively and disappeared during the follow-up. Another case was 76 years old male with a quite large tumor, retroperitoneal tumor. Here, so you can see that dislocation of the spleen, and after seconds you will see the left kidney that it's in the lower abdomen. So, but the tumor was quite well capsulated, so it was not so difficult to remove. With the spleen, it was about 30 centimeters, and the histology was lymphangiosarcoma, and 1 year after the surgeries without signs of recurrence. Another case, when I spoke about that, sometimes we have to operate and we cannot discuss the other modalities. It's like this case. So it presented with the pain in the lower abdomen, but his main complaints with the hematuria and the signs of urinary infection. So as you can see on the CT, it's a large tumor involving the sigmoid colon and the urinary bladder. After cystoscopy, it was seen fistula, and double stent placement was done. And we performed Hartmann resection, urinary bladder resection, appendectomy due to infiltration. Here is the specimen, and the scissors here is placed just to demonstrate how wide was the fistula between the colon and the bladder. So the surgery was the only option that we can do. The patient underwent adjuvant chemotherapy, and now 2 years after the surgery is without signs of recurrence. And the last case that we want to share with you, it's something that I can explain as an out of label case, because it was 79 years old female. It was the complaints in our department was lower abdominal pain, weight loss, general weakness, and difficulty in defecation. Her history starts 3 years prior to admission in our hospital with a lesion of the left thigh that was resected. The histology then was lymphoepithelioma-like carcinoma. 6 months later, left inguinal lymphadenectomy for biopsy, but even the histology was consulted in several clinics in Bulgaria and in Germany. It was not clear the primary origin of that carcinoma, and she started chemotherapy for the protocol for unclear primary origin. And for the next 2 years, she spent changing of the chemotherapy several times, and during these years, a formation in the right abdomen appears, but as previously said, the multidisciplinary collaboration is very important, and actually, that's an example of not good communication, because that patient was referred to us after the oncologist said, so we can do nothing anymore. 2 years they try another therapy, and the tumors grows and grows, and we decided to operate her because the CT shows a large tumor formation that is infiltrating the valvular bauchini, at the same time the duodenum and the mesenterium of the sigmoid colon. So we have to solve the problem with the passage, but if we perform only bypass operation, we have to bypass the duodenum, bypass the right colon. At the same time, we need to restore the passage of the stool in the left colon. So, and because nevertheless that the age was advanced, she was in good condition, and we decided to proceed with an operation. And we performed the tumor extirpation with right hemicolectomy, resection of the right ureter, Hartmann sigmoid resection, partial duodenal resection, and omentectomy. On the screen, you can see the involvement, the transmural involvement of the right colon and the valvular bauchini. So she was discharged on the 10th day after the operation in very good condition, and the patient survived 18 months, and actually she died from myocardial infarction in another clinic without signs of a recurrence. So as a conclusion, the future of the multivisceral resection is not doing more, but doing in the right patient at the right time for the right biological disease. So this is where the surgery stopped being technical and becomes strategic. Thank you for your attention.